Nervous System, Part 4. The neurotransmitter of all motor neurons is acetylcholine, and the receptors of the neuromuscular junctions are nicotine acetylcholine receptors. Motor neurons are controlled by an ascending hierarchy of synaptic inputs that build from involuntary local control to gross postural and balance regulation, to spinal and brainstem generation of commonly used patterns such as walking, to skillful voluntary movements. Alpha motor neurons are located in the spinal cord ventral horn and in the cranial nerve nuclei. Motor neuron axons leave via the ventral roots, traveling through the spinal nerves and peripheral nerves to reach the skeletal muscle targets. The neurotransmitter of all motor neurons is acetylcholine. Spinal motor neurons are located in pools within the ventral horn, with the most medial motor neurons innervating muscles of the trunk, which is the back, ribs, and abdominal muscles. As these muscles are found along the central axis of the body, they are also known as axial muscles. When moving laterally, the next group of motor neurons innervates the shoulder in the cervical spinal cord or the hips in the lumbar spinal cord. The muscles that connect the trunk to the arms and legs are known as the girdle muscles. The most lateral clusters of motor neurons innervate muscles of the arms at the cervical cord and the legs at the lumbar cord. Motor neurons to physiological flexors are found lateral to those innervating the extensors. Motor neuron axons branch when they reach their peripheral muscle targets, forming synapses on individual fibers within a muscle. At the specialized neuromuscular junction, acetylcholine is released in response to motor neuron action potentials. The acetylcholine diffuses across the synaptic cleft to bind to muscle nicotinic receptors, depolarizing the postsynaptic membrane and producing the muscle action potential that leads to a contraction. Acetylcholinesterase breaks down acetylcholine into choline and acetic acid. This will terminate the transmission. Lower motor neuron lesions clinical findings can result from disease processes that affect the motor neuron cell body, shown at number 1, or its axon within the spinal nerve at number 2, or in or near the neuromuscular junction at number 3. In each of these, the failure of the motor neuron function produces a weakness or absent voluntary movement and stretch reflexes, along with atrophy of the target muscle. Lower motor neuron lesions can occur from damage to any part of the motor neuron and can include diseases or trauma that cause any of the following. Number 1, the death of motor neuron cell bodies. 2, compression of ventral roots, spinal nerves, or peripheral nerves. 3, demyelination of peripheral nerves, as in Guillain-Barré syndrome. Signs and symptoms that might be seen with lower motor neuron lesions will include a weakness or complete inability to move the affected muscle, lack of stretch reflex response, flaccidity to passive movement, and muscle atrophy. The muscle stretch reflex relies on the circuitry of the muscle spindle and the excitatory input to the motor neurons surrounding the muscle. The normal function of the spindle input to the motor neurons is to detect the muscle length and to amplify excitation if the desired muscle contraction to accomplish a goal has not been reached. To test a reflex during a neurologic examination, it is using the following chain of events. A brief tap on the tendon lengthens the muscle, increasing the muscle spindle action potential activity. The action potential is then propagated to the spinal cord by the LA axon. As the action potential reaches the synapse on the motor neuron, glutamate is released, exciting the motor neuron. The motor neuron action potential firing rate increases, leading to a reflexive muscle contraction. Motor neurons in the spinal and ventral horn are controlled by synaptic inputs from several hierarchy arranged sources. At the spinal level, muscle sensory input from muscle spindles and Golgi tendon organs provide excitation and inhibition. The brainstem, reticular, and vestibular nuclei project to the spinal cord in the retrospinal and vestibulospinal tracts, generally exciting stretch reflexes and extensory muscles, as well as promoting the tone of the core muscles for posture and balance. The cerebral cortex plans and modifies movements in conjunction with the basal ganglia and the cerebellum. This will ultimately project to the spinal cord by the corticospinal tract. The corticospinal tract initiates voluntary movements, routinely fine movements of the hand and face, and activity of flexors over extensors. It directly and indirectly inhibits stretch reflexes. The pathways shown here give off axons at each level and primarily influence adjacent motor neurons to axonal muscles. The medial pathways facilitate posture and balance and stimulate extensor muscles and increase reflex tone. The lateral white matter exerts great influence on motor neurons to distal muscles of the limbs and flexor muscles, and it inhibits stretch reflexes. The corresponding lateral descending pathways from the regions are the corticospinal tract and the rubrospinal tract. The corticospinal tract plays the greatest role in motor control, while the rubrospinal tract serves to facilitate the actions of the corticospinal tract. These are the various functions of the corticospinal tract. It has control over voluntary coordinated movements, so that would be movements of the arms and legs. It controls the brainstem motor centers, and it is subject to modulation by the basal ganglia and the cerebellar circuits. After a stroke or other damage to the motor cortex, inputs to the brainstem nuclei and to the spinal cord are lost, shown as red X's in the image. This is manifested by weakness contralateral to the lesion and loss of fine movements of fingers and hands. At this same time, the relative impact of the brainstem reticular and vestibular nuclei on motor function is increased. Depending on the site and the extent of motor cortex or internal capsule damage, the patient may develop forearm flexion and pronation and leg extension to the affected side. The loss of descending inhibition and a general increase in spinal excitability produces hyperreflexia of the affected muscles. Decorticate posture is arm flexor rigidity and leg extensor rigidity, often seen unilaterally after a stroke. The decerebrate posturing is when the arms and legs are rigidly held in the extensor position. The projections between excitation, which are the black arrows, and inhibition, which are the red dashed lines, are shown in the image. Motor control by the striatum is modulated by the balance of dopamine and acetylcholine. Neurodegenerative loss of substantial nigra-dopamine neurons contributes to the motor manifestations in Parkinson's disease. Parkinson's disease is the most common movement disorder. A major manifestation of the disorder is akinesia, the lack of movement, or bradykinesia, which is slow movement. Parkinson's also has features of increased motor tone. These increased motor tones will include tremors, rigidity, or both. The cerebellum receives input from the cerebral cortex as a movement is being planned. During the movement, spinocerebellar tracts feed proprioceptive information back to the cerebellum, where the movement in progress is compared to the initial plan. The cerebellar outputs feed back to the red nucleus and via the thalamus to the cortex to correct any movements in progress. The function of the cerebellum is to initiate movement, to refine movements in progress, and to increase further refinement after repeated practice. Cerebellar dysfunction can result from things like stroke or tumors. It can be congenital, as in a hereditary disease. A common finding is ataxia, which is a term that indicates uncoordinated movements and broad-based, unstable gait.